Welcome to the Deep Dive. This is your shortcut, really, to getting genuinely well-informed. We cut through all that noise, to find the most vital insights. And today we're doing a really crucial deep dive aimed right at you, our future nurses. Yeah, this isn't like just theory. It's about connecting it all to real-world patient care, getting you ready. So our focus today, a really comprehensive look at impulse control disorders, and we're going straight to the source, a key chapter in Varkaroli's The Foundations of Psychiatric Mental Health Nursing. Our goal isn't just, listing facts. It's about finding those aha moments that link the textbook stuff to what you'll actually see and do, boosting your assessment skills, your intervention ideas, helping you prep for NCLEX and, well, everything after.
Exactly. Our mission here is to make these core psychiatric nursing concepts, things like assessment, intervention, make them clear. We want to make the complex terms digestible, truly meaningful. And we'll use clinical examples, to bring these disorders to life, show you how relevant they are to your practice. It's kind of like connecting the neuroscience to the bedside, giving you insights you won't just memorize, but actually understand and apply.
Okay, so let's really get into this. Impulse control disorders.
Yeah.
They are profoundly misunderstood, aren't they? People often just write them off as bad behavior.
Right. But it's so much deeper than that. These are complex conditions, psychiatric conditions, really. And they don't just cause minor problems. They can completely disrupt someone's life, devastate families.
And even lead to serious legal trouble.
Absolutely. At their core, these disorders involve aggressive behaviors and really intense emotions. Think about it. If you can't relate to others in socially acceptable ways, it leads to isolation, broken relationships, just immense pain for everyone involved.
Which is why catching them early is so vital.
Exactly. Early recognition, early treatment. It's preventative. It can potentially head off years of struggle, maybe even keep people out of the criminal justice system. So the DSM-5, that's our diagnostic manual. It lifts three main ones under this umbrella. There's oppositional defiant disorder, we'll call it ODD, intermittent explosive disorder, or IED, and conduct disorder, CD. We'll also briefly mention pyromania and kleptomania, which are sort of related.
Okay, let's start with ODD, oppositional defiant disorder. It's really important to get this right. This isn't just a kid being difficult. I mean, some defiance is normal, right? Especially in certain developmental stages.
Totally normal. But with ODD, the defiance is persistent and it significantly impairs their life. School, friends, family life, it hits everything. And it affects both their emotions, think anger, irritation, and their behaviors, like arguing, refusing to comply.
So how is it formally diagnosed? What are the DSM-5 criteria nurses need to know?
Good question. They're quite specific. There are three main categories of symptoms. First, there's angry, irritable mood. This means they often lose their temper, get easily annoyed, or are just generally angry and resentful. Second, argumentative defiant behavior. So arguing with adults or authority figures, actively defying rules, deliberately annoying people, blaming others, that kind of thing. And third is vindictiveness. They've been spiteful or vindictive at least twice in the past 6 months.
And there are rules about frequency.
Yes. For kids under 5, the behavior has to happen most days for at least 6 months. For 5 and older, it's at least once a week for 6 months. And crucially, it has to cause real distress or impair their functioning socially, academically, and it can't be better explained by another disorder, like psychosis or depression.
What do we know about who gets ODD, the epidemiology?
It's usually diagnosed around age 8, but you can see signs much earlier, even by age 3. Global prevalence is pretty consistent, nearly 13%. And interestingly, males are diagnosed about 3 times more often than females.
Any thoughts on why that gender difference exists?
Well, some research points towards cultural factors, maybe how aggression is viewed or tolerated differently in boys versus girls. But it's complex.
Does ODD usually show up alone, or are there other conditions that often go along with it?
Oh, it rarely travels alone. Comorbidities are very common. ADHD, attention deficit hyperactivity disorder, is the big one. Almost 40% of kids with ODD also have ADHD. You also see a lot of anxiety and depressive disorders.
And how do you tell it apart from conduct disorder?
That's a key distinction. Conduct disorder, or CD, is much more severe. CD involves aggression towards people or animals, destroying property, stealing, major rule violations. ODD is more about that emotional dysregulation, the anger, the irritability, the defiance, which isn't a core criterion for CD in the same way, though ODD can sometimes develop into CD later on.
Yeah. What puts someone at risk for developing ODD?
It's a mix, really. Biological, genetic, neurobiological, and environmental factors all seem to play a part.
Biologically.
Yeah, some studies link a low resting heart rate to increased aggression. The idea is maybe they have lower physiological arousal, so typical punishments don't deter them as much.
Interesting. And genetics.
There's definitely a genetic component. Estimates range from 40 to 60% heritability for aggressive and antisocial behavior. A family history of mental illness is also common.
What about the brain itself? Neurobiology.
This is fascinating. They found less dense gray matter in the left prefrontal cortex. Think of that as the brain's impulse control center, the brakes. Also, smaller structures or lower activity in areas like the amygdala, which handles emotions, and the insula involved in empathy. On the flip side, sometimes increased gray matter in the left temporal area, which is linked to impulsivity. And neurotransmitter imbalances, serotonin, norepinephrine, dopamine, plus hormonal factors like cortisol and testosterone, they all contribute.
Wow, quite a complex picture neurobiologically. What about the environment?
Hugely important. Things like family distress, really inadequate or chaotic parenting, insecure attachment between parent and child, harsh or neglectful families, child abuse.
So, tough home lives.
Exactly. Also, socioeconomic status, neighborhood violence, just a lack of structure at home can all increase risk.
Given all that, how is ODD treated?
It really needs a multifaceted approach. Psychosocial interventions are key. Things like parent training programs, absolutely essential. Also group therapy for the kids, anger management skills, cognitive behavioral therapy, or CBT. For younger kids, focusing on the parents, maybe through home visits or programs like Head Start, can make a huge difference down the line.
Is medication used?
Well, there are no FDA-approved drugs specifically for ODD, but meds are often used off-label to help manage the anger and aggression, like divalproex sodium. More often, you're treating the comorbid conditions. So, psychostimulants, alpha-2 agonists, or atomoxetine for ADHD symptoms can indirectly help reduce the oppositional behaviors.
The chapter includes a really striking case study, the boy from India with oppositional defiant disorder who sweated blood. Can you walk us through that?
Yeah, it's a powerful example. This was a 10-year-old boy who had these episodes where blood would actually ooze from his navel, eyes, ears, nose. And these episodes were clearly linked to emotionally intense moments right before exams, during fights with his parents.
Sweating blood. Is that even possible?
It's a rare condition called hematohydrosis, linked to extreme stress or emotional intensity. He was the only son, apparently very pampered. The clinicians linked these physical symptoms to his underlying ODD and the intense emotions he couldn't manage.
So how do they treat him?
It was a combination. Meds, first lorazepam for anxiety, propranolol for the physical symptoms like heart rate, plus relaxation techniques. But the behavioral part was crucial. They worked on decreasing unhealthy parent-child contact, cutting out the secondary gain of, the attention or avoidance his symptoms got him, and really empowering the parents with positive reinforcement, timeouts, a token economy, teaching them to reward the good behavior and ignore the bad.
And did it work?
Dramatically. The bleeding stopped within 20 days in the hospital, and his overall behavior really improved. It just shows how tackling the emotional and behavioral roots together can make a massive difference.
What a case. Okay, let's shift gears to intermittent explosive disorder, or IED.
Right. IED is different. It's characterized by these recurrent aggressive outbursts where the person just cannot control their aggressive impulses. It can be verbal aggression, physical aggression, directed at people, objects, even themselves.
Like road rage, maybe?
That's a classic example. A minor trigger, like someone driving slowly, leads to this huge, disproportionate, potentially dangerous reaction. And a key feature of IED is this rage to remorse cycle.
Rapes for remorse.
Yeah. There's this buildup of tension or arousal, then the explosive behavior happens. Immediately after, there's often a sense of relief or release. But then later, sometimes minutes, sometimes hours, comes the remorse, the regret, the embarrassment, like, wow, I can't believe I did that. I risked my life over nothing.
That sounds incredibly disruptive.
It is. It damages relationships, causes problems at work, can lead to legal issues, and the chronic stress can even contribute to physical health problems like high blood pressure or diabetes.
What are the specific DSM-5 criteria for IED?
Okay, so it involves recurrent outbursts, either verbal aggression or non-damaging physical aggression, happening about twice a week for 3 months. Or 3 outbursts within a year that do involve damage to property or injury to animals or people. And critically, the aggression has to be way out of proportion to whatever triggered it. It's not premeditated, it's impulsive, and it causes significant distress or impairment. Plus, the person has to be at least 6 years old.
How common is IED?
Lifetime prevalence is around 7%. It's seen more often in males, usually starts in childhood or adolescence, and it's more common in people under 50. And like ODD, it often comes with friends. Comorbidities like depression, anxiety, substance use disorders are common. Also, antisocial and borderline personality disorders, and ADHD.
What are the risk factors here? Similar to ODD.
Some overlap, but some distinct factors too. Biologically, things like higher inflammatory markers, maybe higher testosterone levels. Neurobiologically, there's some evidence linking it to loss of neurons in the amygdala and hippocampus, and issues with serotonin in the limbic system, the brain's emotional hub.
And environmentally.
Big factors here. Family conflict, family violence, early exposure to violence, a family history of addiction, and childhood maltreatment, especially physical or sexual abuse, are all strongly linked.
How is IED treated?
Again, usually a combination. Psychosocially, individual and group cognitive behavioral therapy, CBT, is often effective, helping people recognize triggers, manage anger, develop coping skills. Pharmacologically, it's mostly off-label use. SSRIs, antidepressants like fluoxetine or paroxetine are common, based on the theory that serotonin dysfunction might be involved. The citalopram might even help with social understanding. Mood stabilizers, anticonvulsants, maybe some antipsychotics can help too. Beta blockers sometimes calm the physical arousal.
Any medications to be wary of?
Yes, absolutely crucial point for nurses. Avoid benzodiazepines, things like Valium or Xanax. They can actually lower inhibitions, much like alcohol does, and potentially make the aggressive outbursts worse. Really important to remember.
Got it. Avoid benzos. Now, the chapter mentions some interesting research on emotional intelligence and IED.
Yeah, a study called Emotional Intelligence, a Deficit in Intermittent Explosive Disorder. The researchers wondered if people with IED struggle with recognizing, understanding, and managing emotions, basically, emotional intelligence. And they found that people with IED did score lower, specifically on strategic emotional intelligence. And this lower score was linked to thinking others are hostile towards them and having hostile automatic thoughts, especially in those with a history of aggression.
Why is that important for nurses?
Because it points to new treatment targets. If we know deficits in emotional intelligence are part of the problem, we can intervene there. Nurses can help patients see the link between their angry thoughts and their aggressive actions. It's basic CBT, really helping them spot those negative thoughts and replace them with more adaptive ones, building those self-regulation skills.
Okay, moving on to the third major one, conduct disorder, or CD. How does this differ from ODD and IED?
Conduct disorder is generally considered more severe than ODD. It's a persistent pattern where the person basically violates the basic rights of others or ignores major societal rules and norms.
That's what we're talking about.
Things like aggression, bullying, starting fights, being cruel to people or animals, using weapons, destruction of property like setting fires or vandalism, deceitfulness or theft, breaking and entering, lying, stealing, and serious rule violations like running away from home, staying out late, skipping school. It's a consistent pattern.
Does this affect their school performance?
Often, yes. Even if their intelligence is normal, they frequently struggle academically. Truancy, suspensions, getting expelled, dropping out, it's common. And complications like juvenile delinquency and substance abuse often follow. They often seem to crave excitement and disregard consequences. It's a very concerning pattern.
The chapter mentions two subtypes.
Right. Childhood onset, which means symptoms appear before age 10. This is more common in males, often involves physical aggression, poor relationships with peers, and disturbingly, often a lack of guilt or remorse. They might see others as hostile and feel justified in lashing out. Childhood onset has a much higher risk of persisting and potentially developing into antisocial personality disorder in adulthood if there isn't intensive intervention.
And the other subtype.
Adolescent onset. Here, there are no significant symptoms before age 10. The acting out often happens more with peers, maybe risky sexual behavior, substance use, joyriding, that sort of thing. Gender rates are more equal in this subtype.
There's also mention of a callous and unemotional subset.
Yes, this is a really important specifier for conduct disorder. These individuals show a profound lack of empathy. They're unconcerned about others' feelings, don't feel guilty unless they're caught or facing punishment, and often have a very shallow or superficial emotional expression. These traits are a strong predictor for developing antisocial personality disorder later on. It flags a particularly severe form of the disorder.
Can you quickly run through the DSM-5 criteria for CD?
Sure. You need at least 3 specific symptoms from 4 main categories over the past 12 months, with at least 1 symptom present in the last 6 months. The categories are aggression to people and animals, Bullying, fighting, cruelty, weapon use, forced sex, confrontational theft, destruction of property, fire setting, vandalism, deceitfulness or theft, breaking in, lying for gain, non-confrontational theft, and serious violations of rules, staying out late before 13, running away, truancy before 13. And again, it has to cause significant impairment in social, academic, or occupational functioning.
What's the prevalence of CD?
Lifetime prevalence is around 7%, maybe a bit higher in cities. Childhood onset, as I said, more common in males. Adolescent onset is more evenly split, and it's significantly more common, about 4 times more common in kids who previously had ODD. Shows that potential progression.
What about comorbidities with CD?
Very common. ADHD and ODD are frequent co-travelers, and having both ODD and CD predicts worse outcomes. You also see specific learning disorders, anxiety, depression, bipolar disorders, and definitely substance use disorders.
And the risk factors, similar to the others.
Some overlap, yes. Biologically, slower resting heart rate again, maybe increased testosterone in males. Genetically, risk increases if a parent or sibling has it, but environment is a huge factor. Neurobiologically, we see reduced gray matter in brain areas linked to emotion and empathy, like the anterior insula and left amygdala. And really striking, those with callous and emotional traits show more folding in the cortical insula, but less blood flow in empathy-related regions when they see someone being harmed. It suggests a different wiring for processing others' pain.
And environmental risks.
Very significant. Parental rejection, neglect, inconsistent or harsh discipline, growing up in an institution, chaotic homes, large families, absent or alcoholic fathers, family members with antisocial behavior or substance dependence, peer rejection, violent neighborhoods, hanging out with delinquent peers. It's a long list.
How is conduct disorder treated?
Similar principles to ODD, targeting specific behaviors. Anger management, improving family relationships, parent management training, problem-solving skills training. Multisystemic therapy, which we'll get to, is very important here. Parental involvement is key, but it can be tough if parents have their own issues.
And medications for CD.
The goal is usually to reduce the intensity of aggression and impulsivity so therapy can work. So meds target those symptoms. Things like antidepressants, mood stabilizers, stimulants, especially if ADHD is present, antipsychotics like aripiprazole or risperidone for aggression, anticonvulsants, adrenergic meds. It depends on the individual picture.
Okay, before we move to nursing process, let's quickly cover pyromania and kleptomania.
Right. Pyromania is about repeated, deliberate fire setting. There's tension beforehand, fascination with fire, and pleasure or relief afterwards. It's not about money or revenge or concealing a crime. More common in males, often linked with poor social skills, learning issues, maybe alcohol dependence. In kids, often seen alongside CD or ADHD.
And kleptomania.
This is the recurrent failure to resist impulses to steal things that are not needed for personal use or for their monetary value.
So not stealing because you're poor or want to sell the item.
Exactly. They might steal things they have no use for, things they could easily afford. There's that tension buildup before and relief or pleasure after the theft. It's often linked with addictive behaviors, other impulse issues, impulsive buying, mood disorders like depression or bulimia, anxiety, and personality disorders.
Could you maybe summarize the key differences between ODD, IED, and CD quickly? Like a cheat sheet.
Sure. Think. ODD. Onset, usually childhood adolescence, around 8. Features. Angry, irritable mood, argumentative, defiant behavior, vindictiveness, recognizes others' rights. Might become CD, IED. Onset from age 6 up, mean 13-21. Features. Impulsive, out-of-proportion emotional outbursts, violence, property destruction, early treatment is key. CD, childhood onset 10, worst prognosis, or adolescent onset 10. Features. Violates rights of others, aggression, destruction, deceit, rule violations, more criminal links, potential precursor to antisocial personality disorder.
That's helpful. Okay, let's bring this all back to the nursing process.
Yeah.
How do nurses apply this knowledge? This is really key for students preparing for practice and the NCLEX.
Absolutely. So general assessment. You'll often encounter these patients because their symptoms are severe, or maybe they came in for a comorbid issue like ADHD or depression. A crucial first step, especially with kids, is interviewing both the parents and the child. Start together, maybe, but definitely interview them separately too. You get different perspectives, a fuller picture.
And you mentioned earlier, suicide risk is a major concern.
Huge. Suicide risk assessment is non-negotiable. The impulsivity and aggression inherent in these disorders significantly increase the risk. You have to assess this thoroughly. Ask about past suicidal thoughts, threats, attempts. Do they have a plan now? How lethal is it? Can they access the means? How hopeless do they feel? Any changes in energy? Also, what's going on in their life? Their views on death? Any family history of suicide? Depression, anger, substance use? Are they taking meds? You need the full picture.
What if it's a child or adolescent who doesn't fully grasp the finality of death?
That's a critical point. Their potentially distorted view of death or immature ego doesn't make the intent any less serious. Even if their judgment about lethality is off, you treat any suicidal thought or self-harming behavior like cutting or reckless actions with utmost seriousness. Early intervention, often in an emergency setting, getting parents aware, implementing safety measures immediately. It's paramount.
Are there tools that can help with assessment?
Yes. Assessment tools can be really useful. The chapter mentions one, the Vanderbilt ADHD Diagnostic Teacher Rating Scale. It's actually a figure in the book. It lists various behaviors related to inattention, hyperactivity, ODD, and CD. Teachers, or parents, rate the frequency. Scores of 2 or 3 on the scale for certain items suggest a problem might be present. These tools help objectify and structure your assessment.
Can you give examples of specific things to assess for each disorder?
Sure. For ODD, you want to know. What triggers power struggles? How does the child see their own behavior? Do they understand its impact? Can they feel empathy or remorse? What helps them feel in control? What motivates them? For IED, get a detailed history of the outbursts, frequency, triggers, intensity. Importantly, ask about times they were provoked but didn't explode. What helped them maintain control then? Who's in their support system? Any substance use? For CD, how serious are the behaviors? What kind? Who initiates them? Assess their levels of anxiety, anger, aggression, impulse control. What's their moral development like? Problem-solving skills. Can they form a therapeutic relationship? Maybe use a behavioral contract.
And what about the nurse's own feelings? These behaviors can be tough to deal with.
Absolutely vital. Self-assessment for nurses. Let's be real, these behaviors can be objectionable. You might feel uncomfortable, even unsafe. It's okay to acknowledge that. You might start thinking negatively about the patient, like they're choosing this. But our professional ethics demand we provide equal care. Try to cultivate empathy. Remember, the difficult backgrounds many come from the chaos, the neglect. It helps frame their behavior differently and allows for more therapeutic care.
Okay, so after assessment comes diagnosis. What are typical nursing diagnoses?
They usually center on safety, protecting self and others, and improving coping. So things like risk for suicide, risk for other directed violence, defensive coping, maybe impaired parenting if family dynamics are a major issue.
And the next step, outcomes identification, flows from that.
Exactly. Outcomes are patient-centered goals to reverse the problems identified in the diagnosis. They need to be measurable. So if the diagnosis is risk for suicide, an outcome might be patient will express feelings, verbalize suicidal ideas, refrain from attempts, and plan for the future. For a risk for other directed violence, outcomes could be patient identifies harmful impulses, controls impulses, refrains from aggression. For defensive coping, patient identifies effective coping strategies, uses support systems, tries new coping skills. For impaired parenting, parents participate in therapy, learn, and practice effective parenting skills. You get the idea: specific, measurable goals tied to the diagnosis.
All right, let's talk implementation. This is the doing part, right? Putting interventions into action.
Yes. And with these disorders, it often involves correcting really ingrained patterns, like blaming everyone else or denying responsibility. It's about helping them develop more mature coping skills, more pro-social ways of interacting. Some general interventions apply across the board. Always promote safety first. Build rapport. Set clear, firm limits and expectations. Be consistent with consequences. Provide structure. Give them opportunities to succeed at something, to build self-esteem.
Where does treatment usually happen?
It varies. ODD is often managed outpatient, individual, group, family therapy with a big focus on parent training. CD might require inpatient care for crises, evaluation, or if things are really severe, maybe therapeutic foster care or long-term residential treatment. But interestingly, research really supports intensive community-based programs like multisystemic therapy or MST. These involve teams working intensely with the child and family in their own environment. They show much better long-term results than just placing kids outside the home.
And pharmacological interventions fit in here too.
Yes. As we discussed, used to manage aggression, impulsivity, and those common comorbid conditions like ADHD or depression, making therapy more possible. Your role includes medication education, monitoring effects, and side effects.
What about health teaching and health promotion, specifically for parents and caregivers? What's the nurse's role?
It's huge. You help families understand the disorder and its impact, connect them with support systems, support groups, respite care. Help them set realistic behavioral goals for their child. Teach them specific behavior modification techniques. Role-playing difficult situations with them can be incredibly helpful. Educate about medications. Advocate for them with the school system if needed. Help make the home safe, removing weapons, securing medications, or substances.
Advanced practice nurses have more specialized tools.
They do. Several psychosocial interventions are used by APNs. Cognitive behavioral therapy, CBT, we've mentioned helping patients recognize triggers and develop coping strategies. Psychodynamic psychotherapy might explore deeper feelings driving the anger or rage. Dialectical behavioral therapy, BBT, is really good for impulse control. It teaches skills like mindfulness, emotional regulation, distress tolerance, handling relationships effectively. It's shown success even with incarcerated youth.
I've heard of DBT. What else?
Parent-child interaction therapy, PCIT, is interesting. The therapist coaches the parent through an earpiece while they interact with the child, reinforcing positive behaviors in real time. Parent management training, PMT, focuses just on the parents, teaching positive reinforcement, effective consequences. It has good success rate, around 65% for ODD and CD. And multisystemic therapy, MST, which I mentioned the most intensive, community-based approach, therapists available 24/7 working intensely with caregivers, school, peers, trying to change the whole system around the adolescent.
Wow, some intensive options there. Now let's talk teamwork and safety. The chapter highlights something called expressed emotion.
Yes, this is incredibly important for anyone working with these patients. Expressed emotion, or E, refers to the quality of emotion shown by caregivers or staff. High expressed emotion, think being critical, hostile, authoritarian, getting into power struggles, showing resentment, this increases patient aggression. It escalates things. Even body language, like standing too close or using an angry tone, contributes
So high emotion from staff makes things worse.
significantly. It leads to more confrontation, more need for seclusion or restraint. The goal is low expressed emotion. This means staying calm, using a neutral tone, speaking clearly and simply, setting limits matter-of-factly without using blaming language like "you always" or "I told you."
So keep it calm and neutral.
Exactly. This approach de-escalates, reduces the need for restrictive measures, and actually lowers relapse rates. It's about creating a calm, predictable, safe environment.
You mentioned seclusion and restraint.
They should always be a last resort, used only when immediate safety is threatened, following strict protocols. Techniques like timeout or using a quiet room to reduce stimulation are preferred de-escalation strategies.
Finally, evaluation. How do we know if interventions are working?
The ultimate goal is seeing improvement in self-regulation and social interaction. Can they manage their impulses better? Are they interacting more appropriately? In outpatient settings, you're looking for that gradual shift away from aggression and towards considering others' rights, maintaining control more consistently in their daily life. It's about progress, not perfection.
Okay, so wrapping up this deep dive, it's clear that impulse control disorders are really complex, aren't they? Stemming from this mix of biology, psychology, environment, often difficult, chaotic backgrounds. And for nurses, remembering that high risk for self-harm and violence is just crucial for assessment and safety.
Absolutely. And it highlights the nurse's vital role in every single step. Assessment, diagnosis, implementing evidence-based interventions, always prioritizing safety, empathy, structure, and remembering that low expressed emotion isn't just a technique, it's fundamental to creating a therapeutic space where change can actually happen.
So for all of you listening, your journey as a nursing student isn't just about learning diagnoses and treatments. It's also about developing that deep understanding, that empathy, for people facing these really profound challenges to their own self-control. The final thought to leave you with is this. How will you take what you've learned today and apply it to foster not just control, but true well-being in those who struggle to regulate their most fundamental impulses?